Welcome, everyone. We're going to get started real soon here, right at the top of the hour. All right, welcome. Thank you all for being here today. It's the top of the hour. We're going to get started because we have a tremendous amount of content to try to cover in the next 30 minutes here. We are happy to stay on at the end to answer questions, so please feel free to drop questions in the Q&A box at the bottom of your Zoom interface as we go here, and we will save some time for those at the end. And without further ado, I'm going to hand it over to Will Dials, hearing instrument specialist and co-founder of MVP.
Great. Thanks, Chelsea. I'm going to share my screen here. Okay, does that look all right there? Great. Awesome. Okay, perfect. All right. So the sources behind the data that we're going to be sharing and talking about today, we've got three main sources here. First being the MVP benchmark data set, which consists of approximately 1,277 full-time equivalent providers worth of data representing the independent hearing care market in the United States. We're also going to look at CMS.gov enrollment data for Medicare Advantage enrollment reports and crosswalk data, as well as the U.S. Census for some demographics. So for anybody who's been following us or attended our webinars or read any of our content, we've been tracking this particular trend that we're going to talk about today, which in particular, is the softness in new patients coming into practices, new patient appointments, as well as a kind of unexpected drop in third-party hearing aid sales. And we first uncovered this or noticed this early last year, which we did a webinar in February titled "Where Have All the Patients Gone?", where we kind of looked at some of the relatively, I don't want to say alarming, but we saw some pretty negative trends for the first time in a while. We didn't have any great theories as to why, but we just kind of presented it and looked at some of the data. We quickly kind of, in doing research, looked at what might be happening, and we landed on Medicare Advantage enrollment data and some of the disruptions that took place with that in early 2025 and late 2024. And we did a webinar on that in May about the disruptions in enrollment. We did a full year, 2025 year in review. Presented that in January of this year, where we kind of measured the full impacts as best we could measure them throughout the 2025 and what was a fairly ahistorical year in many ways. Here we are today. We're going to be looking at 2026 year to date, what we can see in essentially the first half of the year in the MVP data set with regards to new patient appointments, TPA volume, and other topics, as well as the Medicare Advantage enrollment data that we have now. Okay, so a quick step back in time. Here's what we presented for the 2025 year in review. Here's the kind of the year-end big number results here. Top line, 4% drop in new patient appointments, 2.5% drop in new patient private pay units, slight drop in overall new patient revenue, and then almost 7% drop in third-party units, which was quite I would say surprising and different from the many years that 5 or 6 years before that, with lots and lots of growth in that particular channel. And why that's concerning, if we look at the demographics, look at the number of people turning 65 or the number of people in the country that are over the age of 65 growing over time, seeing a downward trend in new patient appointments per day is a cause for concern, because we should be, even if it was flat, that would not be great, because as demographics grow, you would hope that the independent channel is getting a larger number of new patients walking through their doors every year. And that's not been the case for the last couple years or 18 months or so. A quick look at what we're seeing so far in the data in 2026. Very similar new patient appointments and third-party results, down about 4% new patients again, and another even slightly larger drop in third-party units than we saw last year, but a similar drop nonetheless. New patient units actually showing a little bit of growth. That would be private pay units specifically. And overall new patient revenue up 6%, which is outpacing the growth in units, which is nice to see. So a little bit of stabilization on the private pay front, but we're still seeing the decline in third party. Okay, so now moving into essentially the meat of this presentation, we're going to be looking at the Medicare Advantage enrollment data for the next several slides here. And what you're looking at on the screen here is Medicare Advantage year-over-year growth rates going back to 2018, traditional Medicare, that's the green line, then the overall Medicare eligible population growth rates. So as you can see, for many years, the growth in Medicare Advantage far outpaced the growth in the eligible population, as well as the growth in traditional Medicare, which was negative for quite a few years. meaning that Medicare Advantage penetration was increasing every single year, going back as far as we're looking at it here. And it went from 36% penetration in 2018 to now sitting at about 51%. But what's interesting is that in the last 2 years, everything's tightened up quite a bit. We're now, for the first time in 2026, we are seeing traditional Medicare growth, which we have not seen. I mean, flat in 2018, but we haven't seen any growth in that particular category, going back as far as we're looking at it here. So that's pretty interesting that all three of these lines have converged at essentially 2%, which is the baseline demographic rate. So we've reached some sort of stasis, perhaps, where roughly 1 in 2 patients is going to be in Medicare Advantage, and the other will be in Medicare. We'll see if that continues, but that's what it looks like right now. Okay, so why is Medicare Advantage declining, at least the growth rates? And and probably more interesting, why is traditional Medicare growing? And it has something to do with this, which we covered this last year. We covered this in a couple of webinars last year, but it comes down to the count of Medicare Advantage enrollees who are in plans that were terminated and non-crosswalked, meaning they weren't terminated but automatically enrolled into a similar plan. These are terminated plans where the carriers essentially were exiting markets or plans entirely. And you can see that going pre-2025, these numbers were effectively a rounding error, 300,000 or so at the maximum. People impacted, that number jumped to 1.5 million in 25, and then again to 2.5 million in 2026. That would be the number of people enrolled in plans in December of the prior year that as of January 1st were dropped. So they have choices for what they can do. They can re-enroll in a different Medicare Advantage plan if they choose. They can revert to Medicare intentionally, or if they do nothing at all, they automatically get reverted to traditional Medicare. So I think the latter two there largely explain the growth in traditional Medicare. And what kind of an impact has this had on third-party volumes in the MVP data set? Well, we can see that in 2024, it topped out at about just under 30% of the overall hearing aid sales were third-party. That has declined to about 25% in the last couple of years. So there appears to be at least a correlation between the disruption in Medicare Advantage and the decline in third-party as a percentage of the total hearing aid sales, what we can see in the MVP data set. Okay, so an obvious question is, where is this happening? Is this just a handful of markets here or there? And the answer to that is essentially no. 79% of eligible Medicare recipients live in a metro area where traditional Medicare is growing. That was 3% in 2022. If you look at large metros, which we define as areas with 25K or more Medicare eligible residents, 28% are in areas where Medicare Advantage is losing penetration, which that was effectively zero as well. In large metros where the Medicare Advantage enrollment itself is shrinking outright, not just the share, 10%. So again, 1 to 2% before. So massive changes in where this is happening and how much people are feeling it. If you look at the bottom left here, you can see just some areas to call out where this appears to be happening the most. And if we look at the metro areas in terms of areas that were with heavy terminations, so lots of terminations versus areas with not so much, we can see that the Medicare Advantage growth is less in the heavy terminated areas and the traditional Medicare growth is higher. So that kind of tracks that the areas with lots of people getting terminated more ended up on original Medicare, either by choice or by inaction. Okay, so if we take a look and see how this shook out by carriers and how they individually were participating in this strategy, we can see that most of these players, we grouped the large Medicare Advantage players into these groups. The regional ones would be like hospital systems in certain areas, not affiliated with the large national players. But we can see that most Medicare Advantage carriers did more terminations in 2026 versus 2025, with United, of the big national players, leading the way there. The one exception to that would be Humana, which terminated a decent amount in 2025, but in 2026, not nearly as much. So most of these players increased their participation in this strategy, where Humana was the one kind of exception there. And if we take a look at when it's all said and done, where things landed in 2026, given the 2.5 million or so people that got terminated, we can see that total Medicare Advantage is sitting at about 37 million, 2% year over year growth, all things considered. The biggest decliner of the large players would be United Healthcare, dropping 7%, largely due to their terminations. Humana seems to have picked up most of the benefited from the enrollment changes there. They grew 23% in their enrollment. They didn't terminate very many. Presumably, they picked up people that were in plans that were terminated, United Healthcare, maybe some of those regional plans. So they show kind of a large enrollment growth year over year, which is interesting. And then kind of varying results down the board. One interesting anecdote, you can see the 75% or 74% growth in the emerging insurtech category. These are companies like Clover and Devoted, Alignment, excuse me, I think. These are technology first companies that are gaining share pretty fast while they still kind of maintain a small share. They are growing pretty rapidly. So it'll be interesting to watch that category going forward. All right. So a key question to answer is why these carriers are participating in this strategy of cutting plans. And I think it has to do with the fact that the funding for Medicare Advantage is wobbling. It's not steady currently. The rates at which the payments are increasing are not keeping up with the medical costs. So, for example, the 2026 rate was 5%, which I think for most people watching this industry, we're pretty pleased with that. CMS proposed a 0.09% rate of increase for 2027 for these plans, which was met with quite a bit of resistance. Stocks for these publicly traded companies all dropped pretty dramatically when that number was released. After a lot of industry pushback, they settled on 2.5%, which is an increase in cost, but below the cost of providing the medical care needed for these plans. So the rates are rising slower than the costs are, and the federal government's made some changes to the way they evaluate risks. There's something called the V28 risk model, which has been phased in between 2024 and now fully enforced in 2026, which effectively it changes the way the coding and the risk score formula can work to effectively lower revenue even further. So all of this means less revenue per member between lower rates and risk adjustments, which is putting pressure on the Medicare Advantage companies to make changes. So what can they do? They can exit regions and shed plans, which they've been doing. That strategy is clearly visible in the public data. One that's perhaps a little less obvious at this point, but is the cutting of benefits. Now, we have seen some of the plans cut OTC benefits and some of the other ancillary benefits that come with Medicare Advantage plans. However, at this point in time, hearing, dental, and vision have largely remained untouched. In terms of their presence as a benefit on these plans, I believe 98% of all Medicare Advantage plans still cover hearing aids. But have the benefits been trimmed? Have they eroded slightly? We hear anecdotes about that. We don't have any real clear data on that, but it's a reasonable kind of inference that given the pressures that some of the benefits might be not quite as rich. And interestingly, the Humana CEO on a Q1 recap call said that the gap between funding and the cost of care has widened. In 2027, benefits will be adjusted with margin recovery the priority. And according to Reuters article in May, analysts expect every insurer to trim benefits, with Humana being the most. Now, will that impact hearing care? Unclear, but I don't think any of it is particularly a good sign for the growth in a third party in the independent market. Okay, so what do we see in the MVP data set? So as we saw earlier, we're seeing a 7.6% drop year over year in third-party units over what was a pretty soft start to 2025 as well. So that's 2 consecutive years of growth, along with 3.5% growth in private pay units. So that kind of mirrors what we've looked at in the enrollment data, what we can see there with the decline in the growth of Medicare Advantage, the penetration of Medicare Advantage, along with the increase in traditional Medicare. This is kind of the pattern you would expect to see. If we look at the individual carriers that participated in the terminations and then connect that to what we see in the MVP data set in terms of third-party hearing aid companies, pretty interesting to see here. In 2026, unsurprisingly, UHC hearing units down considerably, 23% year-over-year drop in UHC hearing TPA units in the MVP data set, with a slight growth in True Hearing. And just for clarification, True Hearing and Hearing Care Solutions are combined in both this year and in the historical periods so that we don't overstate any growth given their merger and operating essentially as one entity now. And then all of the other players involved show a slight year-over-year decline, minus 1.5%. Okay, if we look at this over the past 2 years, because now we have 2 years of this kind of behavior of the carriers of dropping plans. So United Healthcare down 23% this year. 2025, we saw a drop of just about 2%. So essentially flat. They didn't really participate in the terminations as much in 2025. So makes sense that they didn't drop nearly as much last year, but are down quite a bit this year. True Hearing had a big drop last year. Presumably that might have had something to do with Humana doing some fairly large terminations and then growing a bunch. Now, True Hearing works with not just Humana. There's lots of other carriers involved, some with growth, some with decline. So it's a little bit of a mixed bag, but overall, the True Hearing numbers in the independent channel, at least within the MVP data set in 2026, are showing some growth. And then on the other side, the other companies are essentially flat this year, when they were down 8% last year. So this kind of maps onto the enrollment data, and you could infer that the plans that terminate many, that the TPA companies that are affiliated with plans that are terminating large members are going to see an impact in overall hearing aid volumes in the third-party channel. Okay. So we've established that the new patient appointments are down. So the top of the funnel has been softening. So we looked at this in the year in review, and we thought it would be worth kind of making sure things haven't changed from this perspective. And we calculate something called a full funnel conversion rate, which is doesn't qualify the new patients, doesn't care if a patient comes in for an HAE or if it's a cerumen removal or anything in between, just total number of people walking through the door, and then how many people end up in hearing aids, third party, private pay, doesn't matter for this particular calculation. And we can see the funnel shrinking, and we can see that the conversion rates are exactly the same. So this just speaks to the fact that the effectiveness of the channel, the candidacy rates, things like that are largely unchanged. It's simply the top of the funnel has been shrinking now for several years. And if we look at where the patients are coming from, we group referral sources in the MVP data set into some of these big categories. Caveat, we can identify about 2/3 of all referral sources. So that's what we're focusing on here, is the referral sources that we can in fact identify. And we're plotting them. What we're looking at here is the same period of time, so 2026 year to date, and those same dates in 25, 24, 23, and 22. So we have a true apples to apples comparison of what the first half of the year looks like to get an idea of what's changing with these various marketing channels. So the red line is the insurance and managed care referrals, which we can see 2 consecutive years of downward trend. Interestingly, physician referrals also down. We've long thought that the obvious connection between the Medicare Advantage disruption and insurance managed care referrals, that makes sense why those would move together. We think that there's probably an impact on physician referrals as well, because if a patient is dropped by their insurance and they have to find a new insurance carrier, a new plan, they might need to find a new primary care physician, new specialists, things like that. We think that could be disruptive of the physician referral side of the business as well, although a little bit trickier to measure. All that said, organic referrals, which would be things like word of mouth, patient referral, those are up a little bit year over year. Online is up. It's the only category here to consistently grow over this entire period, which is interesting. But yeah, a 17% drop in insurance managed care referrals in the MVP data set this year. And if we look at which of these categories result more in third party versus private pay units, pretty not surprising, but interesting to confirm that the insurance and managed care referrals results in, of the ones that turn into hearing aid sales, about 75% are third party. So the drop in that particular category is largely responsible for the drop in the third party units that we're seeing in the data. And not all referral sources or types of patients are equal from a revenue per opportunity perspective. So that drop in insurance, we wanted to try to quantify it and see how impactful it might be. And what this just tells us here is that for every new patient opportunity you get from an insurance company or managed care company, results in about 1 unit, which is higher if you look at all the others on the screen here than the other sources. But the revenue per opportunity, unsurprisingly, is quite a bit lower due to the lack of private pay sales in those patients. So I think of this, a lot of this, we've been trying to understand why the new patient revenue is growing, even though the new patient appointments are down. It's that the ones we're losing are not the most productive on a per patient basis, is what this says. Each opportunity is worth a little bit more, even though we're losing the insurance and managed care ones, and at least this year so far, the physicians as well. And it hasn't hit the premium segment, which is also interesting. We've been tracking this for some time now. We've been looking at the kind of the splitting of the market, the separation between the premium and advanced segment of the private pay business, and the entry and the basic. So even though new patient appointments are down, you can see that the premium and advanced units are continuing to climb. So the patients we're losing, even on the private pay side, don't appear to be impacting the premium and advanced sales, which suggests we're losing a lower end segment of the new patient business. And if you watched our year in review or any of the stuff we talked about last year, this is another thing we've hit many different ways and continues to be true in 2026, that the existing patient sales, existing patient opportunities are carrying all of the growth that we're seeing in the market largely. Existing patient revenue continues to climb, units up 8%, opportunities up 14. So the practices that have large nurtured databases are the ones that are doing well. And it's the key strategy to succeeding that we've seen over the last couple of years, is really working with your database. But it's masking an underlying problem in theory, in that, if the top of the funnel will stay soft indefinitely, then eventually this existing patient strength may eventually kind of run out, because you can only resell the same people so many times, and this segment of the patient database is getting older. So good to see now, but it's definitely something that we need to pay attention to going forward. Okay, so this is something we've looked at a few different ways, looking at it a little bit differently here. We're measuring the patients moving between TPA and private pay, and the inverse, going from private pay to TPA. So patients whose previous purchase was a third party, second purchase is a private pay, and then the inverse being patients who were previously a private pay patient whose second purchase was third party. Measuring that is the TPA reversion to attrition ratio, where a value of 1 would be equal parity, meaning patients going into each bucket in equal numbers. Below 1 means you're losing patients to third party, private pay flipping to third party. So we were running at about a 0.5 for quite a few years, which means that effectively 2 to 1, for every one patient you flipped from TPA to private pay, you were losing, or the other way around, excuse me. For every one patient you were flipping, every one patient you were flipping from TPA to private pay, you were losing 2 private pay to TPA. So, and now for the first time in 2026, we have more patients moving from third party to private than the other way around. So totally inverting, and also aligns with everything else we've seen with the enrollment data and the sales data alike. Okay, so this is some interesting moves that we've seen from some of the larger players involved in the third party space. Just kind of interesting to see their reactions to what likely are numbers and growth that are not what they've been looking for. Nations Hearing, as many of you I'm sure are aware, has entered into a deal to operate the Sam's Club hearing centers. Very interesting. It will provide a stable network for them to service their Medicare Advantage patients, but it also affords them the ability to ostensibly compete in the private pay, self-pay model as well. And on the other side, we've got Ear Professional Group, which is an umbrella company under United Healthcare that operates UHC. They acquired Soundly, which gives them some opportunity to participate in the direct-to-consumer business, as well as an increased focus on their discount plans through the Medigap or Medicare supplement plans, which are not impacted by the Medicare funding issues. So both of these moves signal not necessarily a divestment from Medicare Advantage spaces by any means, but certainly a diversification and perhaps a little bit less reliance on Medicare Advantage funding, given the what we've seen with the lack of stability in that and perhaps the lack of growth in the hearing aid volumes associated with it. So let's see, how are we doing on time here? All right. Um, we believe Medicare Advantage disruption is almost certainly a driver of many of the things we're seeing. So, Medicare Advantage growth has fallen to the demographic baseline. Traditional Medicare is growing across most of the country. We're seeing drops in Medicare Advantage, managed care units. UHC's decline in 26 and True Hearing gaining kind of mirror the termination in the enrollment data, which lends credibility to the theory. The insurance referrals are down 17%, more than any other source. And we're now seeing more patients flip from TPA to private pay than the reverse for the first time on record. So yeah, this is all kind of correlations. We don't have definitive proof by any means, but we think this all points to the same kind of answer here as to what's going on. And here are some of the things we'll be paying attention to for the second half of the year. We'll start looking for signals in terms of what the large players are thinking about doing in terms of plan exits or maintaining. We should have some of that data later this year, October, November. We'll see if the TPA unit decline increases or stabilizes. We'll obviously be watching the patients flipping between the third party and private pay, and whether we've hit any sort of floor on the new patient growth rates. So with that, I think we're ready to take some questions.
Thanks, Will. Yeah, looks like we've got some popping in here. Okay, well, this one just says very interesting information and well presented. So thank you very much for being here. Lee, it looks like you're raising your hand. Do you want to drop a question into the Q&A and we'll be happy to answer it? Here we go. Oh, this another one just saying thanks for the information. So yeah, no problem. Thanks for being here, Lee. Here's a question. What's the specific time period for the 2026 data?
For the CMS enrollment data, and I should have clarified earlier, I think it's on one of the footnotes on the slides. We use the April data, the April enrollment reports, because we want to give the special enrollment period, which expires March 31st, which is anybody whose plan was terminated. They get a little bit more time to decide where they want to land. So the April is a fully reconciled look at after the enrollment period where people landed. For the MVP
and then just to
data
clarify,
set,
Will, the MVP data is through like Monday, right? Something like that.
Yes. Yeah, and
Great.
depending on which slide, we looked at different periods of time, but yeah, anywhere from 2018 to Monday on the MVP data set.
Great. Okay, someone asking if there'll be a link. Yes, we've recorded this. We will email it out to all registrants and also post it on our YouTube channel. So that'll be available sometime later today or tomorrow. Here's a question. I'm about to acquire a clinic that does some managed care units, and we're considering switching completely to private pay and not taking managed care anymore at this clinic. What are your thoughts on this?
A little hard to answer that question without more data and understanding of the market, the payers, the existing database composition. So I would be happy to talk offline about that and share my thoughts after getting a little bit more information, but I hesitate to make a strong recommendation here. So feel free to reach out to me directly. I'm happy to talk offline.
Great. Someone's asking if you've noticed a difference in the data depending on the region in the country. And I know we spoke a little bit about what we saw regionally in the CMS data, but I'm assuming this question is about maybe more the MVP data set.
Yeah. Yes, we see some differences, although a little hard to discern signal from noise there. Um, there's certainly differences with like retail pricing and ASPs and third party historical like penetration within markets. So yes, it does vary regionally.
Um, Someone's asking if you think this could potentially be related to the K-shaped economy where premium is growing, but overall numbers are down. Some people going to Costco, other lower cost options that we might not have visibility to in the data set.
Yeah, I think that's a totally plausible theory. And you're right, the premium and advanced slide that literally looks like a K-shaped economy. Uh, so I do think that that's possible. I don't know if that's, there's other things at play, but I think that's a reasonable theory. Yes.
Someone's asking for clarification on how we track third-party conversions to private pay within MVP.
So yeah, so we with on the back end of MVP, we have all sorts of different logic and processes that run that um, are able to distinguish between the two based on the way the invoices are generated within the office management system. Sometimes, as part of the onboarding process to MVP, we look at that, we talk to the account, we figure out how they've invoiced them both in the current period and how they've done it historically. And we sometimes make some tweaks to that to fully capture it, but essentially each sale is evaluated and determined whether it's private pay, third party, or some other sort of non-hearing aid revenue transaction.
Great. And here's a kind of a related question. The third party private pay indicator that you shared on the attrition and conversion graph, well, it says it's over 1.0 now. Is the going assumption that these are third parties that converted to private pay or true private pay? And I think the answer there is we're only looking at people who were formerly TPA who now purchase private. So unrelated would be anybody who's historically always been private pay. Yeah.
That's correct. Yeah.
Okay. Okay. Let's see. We have a bunch coming in. Yeah, another question about the recording. Yes, we'll make that available. Um, I know you're, I don't know how you're going to want to answer this one, but how about recommendations for changes in marketing as a result of this data?
Yeah, I mean, full disclosure, I'm not a marketing expert. We can look at the trends and see what's working, what's growing, what's declining. Online, which I know that's a big category, is the only source that's continuously growing. Traditional advertising in the form of direct mail is declining year over year. I wonder how much some of that is due to just choices of investment, as opposed to it actually like delivering less patients per dollar spent or whatever the case may be. Because we do see plenty of examples of practices doing well with that strategy. It probably depends on your market and the competitive landscape. So, not really, other than understanding your data, your market, and working with experts who do understand, have their finger on the pulse of what's driving patients into practices in the independent channel.
That's what I was going to say too. Just making sure using a tool like MVP to really understand your market and your practice and your position within it and what's happening on a daily basis will inform those decisions. Obviously, going to be unique for every practice, though. Will, someone's asking what percentage of TPA opportunities overall are converted to private pay, or I guess maybe like flipped to private pay. I'm not sure if that's a stat we've looked at or have handy.
Yeah, it's not, because it's really hard. It's easy to identify a TPA conversion or a private pay sale, or those are very easy to identify in the data based on the way they're invoiced and the revenues and units and things like that. But the opportunity side is trickier just because many practice, if you use specific appointment types like third party HAE, private pay HAE, that can be a pretty good indicator as to which is which, but vast majority of practices do not. And even, with 98% of Medicare Advantage plans having a hearing aid benefit, and that representing approximately 50% of all people over the age of 65. So many of the opportunities that sit at your desk have some sort of third party benefit like available to them. So like, I don't want to say they're all third party opportunities, but a lot of them are. And we know that many of those don't end up in private pay. It all depends on how they're routed to you. So no, long rambling answer to say we don't really know.
Okay, great. That's all the questions I have as of right now. So if anyone else has one, feel free to drop it in. We're happy to stay and answer it. Um, okay. Okay. Excellent. Well, thank you so much, everyone, for being here. If you want to get in touch with us, myvitalspro.com. I'm happy to chat with anybody about their specific situation. But appreciate you guys being here, and we'll see you soon.